Hi, good morning, good evening, good afternoon, wherever you are. Welcome to this webinar by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Saint Antoine Hospital and Sorbonne University in Paris, in France. It is 6 p.m. Now in Paris, 5 p.m. in London, 7 p.m. in Jerusalem and Amman, but also 9 a.m. in Duarte, because today our guest speaker is Dr. Ibrahim Aldoss, who is an associate professor in the Department of Hematology and Stem Cell Transplantation at City of Hope. He's also an active member of the Guerre Family Center Leukemia and co-director of the Hematology Tissue Bank at City of Hope, but also co-director of the Leukemia Registry. And when you look into his title, you can easily guess that his primary research focus is about the treatment of younger adults with ALL, but also immune therapy for ALL. He completed his residency in internal medicine at the Creighton University in Omaha, Nebraska, before joining the Keck School of Medicine at USC to do his fellowship in hematology oncology. So we're very pleased and honored to have Dr. Aldoss with us today, and he will tackle a very difficult topic, namely the treatment of Philadelphia-like ALL in adults. And you may have seen that this month, the November monthly webinars of the ICH were actually dedicated to the hard-to-treat ALL patient, because last week we had Professor Xiaoxun Huang from Beijing, who discussed the treatment of T-ALL, which is another hard-to-treat entity. As you all know, it's a highly interactive educational activity, and we would welcome your questions, your comments to Dr. Aldoss, and I will be more than happy to share these questions with him at the end of his presentation, and we can have a live Q&A, and we are fully live, by the way, now. So without any further delay, I'd like to welcome Dr. Aldoss. Thank you very much, Ibrahim, for making the time. I know it's the beginning of a busy day, but still, you kindly accepted to deliver this webinar. So the floor is yours.
Thank you, Dr. Moti. It's a great pleasure to be here and present on the treatment of PH-like ALL in adults. So let me start. So these are my disclosures. So PH-like ALL, it's kind of relatively newly described entity of B-cell ALL. And what's unique about it, that the gene expression profile of these cases kind of resemble the Philadelphia chromosome positive ALL, but they usually lack the BCR-ABL fusions. And PH-like ALL is an important entity because it's a high-risk subtype of B-cell ALL. They tend to be chemorefractory, where frequently they're refractory to initial induction, and for patients to achieve remission, they frequently have persistent MRD after induction and consolidation. And another important part of PH-like ALL is not uncommon. I mean, at least in the US, but even some countries in Europe, like Italy, I mean, it seems that this entity is not uncommon and can present between 20 to 30% of all cases of B-cell ALL. Now, the majority of these cases, they will carry recurrent genetic alteration that either activate kinases or cytokine receptor signal pathways, and that actually kind of motivate the potential of targeting these entities with tyrosine kinase inhibitor. However, the diagnosis of this entity remains a challenge, and truly there's no consensus how to define it, what diagnostic methodology or tools to use to make these diagnoses, especially when you have cases that they lack the defining fusions. So this is from the US, large retrospective analysis of adults with BCL-ALL, close to 800 patients with ALL. You can see that PH-like ALL represented 24% of all these cases. And this is comparable to the frequency of Philadelphia chromosome positive ALL. Now, you see the PH-like ALL across all ages. You can see it in younger adults where the incidence as high as 28%, and middle-aged adults, 20%. And surprisingly, even in older adults, you can see that 24% of all these cases were PH-like. And this is different than what was at least reported in Germany, where the initial pediatric cohort shows that the incidence increased with increasing the child age, and kind of peak in adolescents and young adults. But then the German actually published their data, and they show actually it's highest in younger adults and adolescents. But after that, the incidence decreased and become uncommon in actually during adulthood, and less than 10% of cases. While during that time, the PH positive ALL cases increase. Now, PH-like ALL, it's not a single entity. It's a heterogeneous disease with several genetic subtypes. And you can see the most common one, usually the CRLF2 alterations that can be with JAK mutation or JAK wild type. But there are other genetic entities like the JAK2 rearrangement, the EPO rearrangement cases, the JAK-STAT pathway alterations, the APL classes. And you can see that the frequency of these sub-entities can vary based on the age. Like the APL, you can see it more common in younger adults and become less common in older adults. So this is the SEERS database. This is looking at incidence of different cancers and outcomes in the US. And something unique about PH-like ALL, it's more common in Hispanics, actually Latinos. And you can see that ALL in general incidence has increased over the last couple of years. And if you look at the different ethnicity, you see that Hispanics and Latinos, usually they have the higher incidence, and that has increased across the years as well. This is in green, compared to whites in blue and red for Blacks. And you can see that the incidence of ALL in Hispanics and Latino are higher across all ages in children and adults as well, based on the SEERS database. And that could be related to the polymorphism in GATA3 genes that has been linked to increased incidence of ALL in Hispanics. And it seems that cases that cannot link to the GATA3 polymorphism are usually PH-like ALL, typically CRLF2 rearrangement, and associated with high risk of relapse. So that maybe explain why we see more common PH-like ALL in certain areas in the country compared to others. Depends the distribution of the Hispanic population in the US. So this can actually show this incidence where if you look at states where there is actually enriched in Hispanics and Latinos, where they are on the southern border of the United States, along the border with Mexico, you see like data from MD Anderson, where it is in Texas, that the PH-like represented around 33% of all cases of newly diagnosed BCL-ALL. And you can see compared to non-PH-like and PH-positive, patients with PH-like ALL, they tend to be Hispanic, 68% compared to 35 and 30%. This is data from our center, City of Hope, which is located in California. And California is rich with Hispanic population. And this is mainly data for patients who underwent transplant with PH-negative BCL-ALL. And here we show actually 44% of cases, they have actually PH-like fusions. And when we compare the PH-like fusion cases with non-PH-like, you see the majority of PH-like were actually Hispanic patients. So why PH-like ALL is an important entity? Because these patients, they do poorly with standard chemotherapy. And this is from the multi-center US study that shows that the survival and PFS curves for PH-like ALL is inferior compared to other B-cell ALL. And this can be seen in younger adults, in middle-aged adults, as well as in older adults. And if you look at the recent publication for post-hoc analysis of the ECOG 2993 study, where cases were analyzed with NGS, and they're actually looking at the different new subtypes. You see the PH-like ALL, this is in brown, has one of the worst survival and relapse-free survival in these cases, along with haplodiploidy and other high-risk ALL like BCL2-MYC. So this is why it's an important entity. I mean, there is a really unmet need with the current treatment, and we need to kind of improve on the current treatment by hopefully including TKIs, immune therapy, to improve their outcomes with upfront line therapy. So the question always comes, I mean, is there a superior chemo frontline regimen for PH-like ALL compared to other regimens? And at least in the US, there's always question using something more adult-based regimen like hyper-CVAD versus pediatric-inspired regimens, which has shown in general that in B-cell ALL, they're associated with better outcomes. So on the left side, this is the curve from the CLGB 10403, and this says a pediatric-inspired regimen use one of the arms of the high-risk COG regimen. And you can see even with implementing pediatric-inspired regimen, patients with PH-like ALL, they continue to have inferior survival compared to non-PH-like ALL. And the Anderson, they look at their PH-like cases, and they compare patients treated with augmented BFM versus the ones that treated with hyper-CVAD, and they show actually both they did poorly, and it didn't seem that using one regimen over another was associated with better outcomes. This is another pediatric-inspired regimen. This is the Italian Jamima LALA 1913 study. Surprisingly, at least in the Italian population, it seems the PH-like ALL is not uncommon. I mean, it's 32% of cases actually, they were tested positive for PH-like ALL. But you see, compared to non-PH-like ALL, those with PH-like ALL, they have inferior CR rate, but also higher persistent MRD at all time points at 4 weeks, 10 weeks, 16 weeks compared to non-PH-like ALL. And this also reflected as inferior event-free survival that was still significant in multivariate analysis. So how to approach the induction therapy for adults with newly diagnosed PH-like ALL? I mean, the current data, unfortunately, does not support superiority of one regimen over another. And I think it's very important and key to enroll these patients in clinical studies to kind of see what could potentially improve the outcomes of these patients. And there are studies that are utilizing tyrosine kinase inhibitors with the backbone of the chemotherapy. There are other studies, although they're not specific for PH-like ALL, they include blinatumomab, intuzumab in the backbone frontline therapy, and potentially like post-hoc analysis will show that patients who get treated blina intuzumab, if they have PH-like ALL, potentially they may do better. We have study at City of Hope where we try to enrich for PH-like ALL, where we're actually using venetoclax with the backbone of pediatric-inspired regimen. And this actually enrollment in clinical study become more important in older patients with PH-like ALL, because older patients in general, they don't do well with standard chemotherapy, high rate for toxicity from chemotherapy. And if we know that they're unlikely to respond to chemotherapy because they have PH-like ALL, it becomes important to enroll these patients in novel upfront clinical studies where they're including inotuzumab, blinatumomab, potentially the combination of intuzumab and blinatumomab. Now, if no studies are available, typically for younger patients, we induce with the AYA regimen, but we move quickly to immune therapy for persistent disease, including MRD. And for older patients, if there's no clinical studies available, I mean, typically we try to give mild chemotherapy more as site reduction so we can justify moving to one of the novel therapies, either intuzumab or blinatumomab. Now, an important topic comes up when we discuss PH-like ALL, since they frequently have alteration that activate kinase and cytokine receptors. What's the role of the tyrosine kinase therapy in these cases? At least in preclinical studies, it shows that PH-like ALL can be sensitive to TKI, but it depends which genetic alterations they have. You can see drugs like the dasatinib, they're effective in APL class fusions. You have JAK2 inhibitors in patients with CRLF2, JAK2, EPOR even. You have crizotinib, can be active in NTRK3 fusions. Now, unfortunately, data is very limited at this time. There are some retrospective analysis. This is one of them in children with APL class fusions, where they compare the outcomes of patients who receive TKI as part of the backbone of the chemotherapy, and frequently because they have persistent MRD or induction failure, versus kind of more historical cases that did not receive TKI. And here they show potentially the relapse, especially if no transplant is done, is less in patients who receive TKI, but you can see here that the event-free survival and the overall survival was not different. And there are several actually clinical studies ongoing looking at this question. Well, TKI, either a single agent or in combination with chemotherapy, can have activity in patients with PH-like ALL. And you can see most of them, they including either ruxolitinib or dasatinib as TKI based on the genetic alterations they have. But some studies actually, especially using single agent TKI, like this is from MD Anderson, was actually terminated early because there was lack of response and slow accrual as well. But potentially these TKIs can be given in combination with chemotherapy or in combination with other tyrosine kinase inhibitors. You can see that this is a preclinical data actually was published recently looking at cases with EPOR-IGH fusions, and these tend to be very chemo-resistant, where they actually treat cases with ponatinib, ruxolitinib, or the combination, and you see the combination has synergistic activity in this fusion. And there are other clinical studies still going. This is from the COG, where they actually screen patients for PH-like ALL, and it depends on the fusions, alterations they have. They can be allocated either to receive the dasatinib after the complete induction versus ruxolitinib. And then the ruxolitinib arm, they published the phase 1 part, at least they presented in ASH abstract, that shows that it was safe and tolerable to add ruxolitinib in combination with intensive multi-agent chemotherapy in newly diagnosed high-risk patients with CRLF2 rearrangement or JAK pathway mutated PH-like ALL. But the question, what about the activity? Did it really improve the outcomes of these patients? So there's still no data, but at least this is from the phase 1 study. They had 11 patients. Out of 40 discontinued the study. And you can see that some patients, they still can experience relapse as a reason why they discontinue. You have 2 patients to CNS relapse. You still have patients with persistent MRD after consolidation for patient and other reasons as well. But this is a case actually we published a couple of years ago I want to share with you. And maybe this is where actually this TKI can work better as more as a preemptive low disease burden. This is a case of PH-like ALL in younger female, 23 with APL1 fusion, where actually she was refractory to initial induction. We added the dasatinib with the second induction, and she achieved MRD positive CR. She had myeloablative conditioning transplant, and post-transplant day 30, she still has low-level disease, MRD, 0.68%. So we started on the dasatinib on day 35, and we kept checking bone marrow biopsy every few months, and it took her 2 years actually to clear MRD completely. Then after that, I continued the dasatinib for 5 years total, and just recently, a couple months ago, we did bone marrow biopsy, and we checked MRD by multicolor flow and clonoSEQ, and it was negative. And after discussion, we decided to hold the dasatinib and maybe repeat another bone marrow biopsy in a couple months. But the activity of this TKI, it doesn't seem to be the same as what we see in Philadelphia chromosome positive ALL. They may have activity, but I think it fit better for in combination or for low disease burden as a preemptive maintenance therapy. So the role of TKI in combination remain under investigation as single agents. At least the activity appear modest in PH-like ALL with frank disease. It is important to enroll these patients in clinical study utilizing tyrosine kinase inhibitors so we can actually build more data and figure out more if what's the activity of this agent and how best to utilize this agent. Now, adding ABL inhibitors like the dasatinib, imatinib, we know it is safe from our experience in pH-positive ALL and potentially can have activity. And maybe it's a reasonable approach for patients with delayed response or inadequate response to chemotherapy. My own conclusion that at this time, ruxolitinib remain investigational, and the problem is also the toxicity and the risk of cytopenia with the drug. An important question always comes, what do you do with this patient? Now we know they don't do well with chemotherapy. Would you transplant every patient with PH-like ALL and CR1? And this is an important question. I mean, in large proportion of these patients, it's clear that you need to transplant them. And this is because they're frequently either induction failure or persistent MRD. And this can be seen in the Italian study where 40% of PH-like ALL end up going to transplant compared to 11%. And this is just by following the guideline of the trial for patients with persistent MRD, they need to be allocated to transplant. Now, the question, what about adults who achieve MRD negative CR? Would you transplant them? Should you transplant every PH-like ALL and CR1 regardless of early MRD response? So this is data from MD Anderson, where they were treated with high-CVAD, and they look at their PH-like ALL compared to other B-cell ALL for patients who achieve MRD negative PH-like ALL in red. And the blue one is the patient who had MRD positive PH-like ALL. And you can see both outcomes are poor and was not different between achieving MRD negative or positive with this high-risk entity. And this may justify, actually, maybe we should transplant every patient regardless of MRD response. Now, looking at some sub-analysis, and the paper was published by Roberts for PH-like ALL in adults, they look at patients who were enrolled on the ECOG 2993, diagnosed with PH-like ALL, and they look at patients who get transplanted in red versus those who did not get transplanted in blue, and you see both did extremely poor. Now we look at larger experience at City of Hope, and we had 127 adults with PH-negative B-cell ALL who underwent allogeneic transplant in CR, can be CR1, 2, or 3. And doing by NGS and FISH, we actually identify PH-like fusions in 44% of patients. We kept the definition of PH-like restricted to the presence of fusion. And again, because these are high-risk patients, most likely triggered the physician to transplant them, you see that they were very enriched with PH-like ALL. The majority were CRLF2 rearrangement, but you have 18 patients on CRLF2 rearrangement. And when you compare PH-like ALL with non-PH-like ALL, you see PH-like ALL more frequently Hispanics compared to non-PH-like ALL, less likely having high-risk cytogenetic, more frequently had blinatumomab before transplant compared to non-PH-like. But I mean, looking at other factors like donor MRD status at transplant, disease status, conditioning, stem cell source were not different between PH-like and non-PH-like. But for PH-like ALL, actually, they more frequently had to receive at least 2 regimens or more to achieve CR1 among patients who were transplanted in CR1. So possibly maybe higher risk subgroup. Now looking at outcomes, this is relapse-free survival, this is overall survival. You see that PH-like and non-PH-like, there was no difference in relapse-free survival, overall survival, relapse, and non-relapse mortality. And you can see for the whole cohort with the PH-like ALL, the 3-year overall survival was 51%. If we restrict the analysis to patients who were transplanted in CR1, there's also no difference in relapse-free survival, overall survival, and relapse, no relapse mortality. But now we can see that the 3-year survival for PH-like ALL was as high as 68%. Now, not all PH-like ALL, they do the same. I mean, some subgroups, they do worse than others, and especially cases with the CLF2 rearrangement. You can see here in the MD Anderson experience, these are the ones that usually drive the poor prognosis of PH-like ALL. The same thing with the US multicenter study. You see that patients with with CLF2 rearrangement and those with EPO JAK2 fusions, they tend to have the worst outcomes. So what we did, we looked actually at only patients with PH-like ALL who get transplanted and compare outcomes of those with CLF2 in blue and those with non-CLF2 PH-like. And we saw that relapse-free survival and survival outcomes were comparable, even relapse and relapse mortality. But although it was not statistically significant, you can see that relapse was almost twice as common in CLF2 rearranged leukemias compared to non-CLF2 PH-like ALL, 44% to 23%. This is another experience from my clinic looking at transplant in PH-like ALL. I mean, it's a smaller cohort, only 17 patients with PH-like or suspected PH-like. And you see the green curve, it's not inferior to other subtypes of B-cell ALL. So, I mean, it seems at least transplant can overcome the poor prognosis of PH-like ALL. So my conclusion about transplant, that transplant associated with 3-year overall survival exceeding 50% in adults with PH-like ALL and can approach 70% in those transplanted in CR1. We haven't seen difference in survival outcomes between PH-like and non-PH-like. Now, relapse remained the main cause of treatment failure in PH-like ALL, especially in cases with CLF2. I think we have to work better how we can optimize pre and post-transplant preemptive maintenance therapy to reduce the risk of relapse furthermore, so we can improve the survival of these patients. And allogeneic stem cell transplant should be considered for patients with PH-like in CR1. But again, I mean, our data and others yet has not answered the more important question, what about early MRD responders? Will they benefit from transplant in CR1? And my own approach, I take these cases on individual cases. I mean, patient who is persistent MRD after induction, they clear it after consolidation. I tend to take them to transplant if they're PH-like. If the patient develop early aspergillus toxicity, or they're only able to receive 1 dose, maybe that's an indication. Cases with CLF2 rearrangement, EPO rearrangement, I tend to transplant them more frequently, even if they achieve MRD negative CR. Now, moving to the last topic is what about the new novel target therapy and cellular therapy in PH-like ALL? So data, I would say overall, I mean, we're still lacking the data. Large data set, but at least there are some actually early data, small retrospective analysis that show that these novel therapies are active in PH-like ALL and possibly has the same activity as non-PH-like ALL. So this is some work we did with St. Jude, where they analyzed 40 cases of relapsed refractory B-cell ALL treated with blinatumomab at City of Hope. And we're able to find that half of these cases are actually PH-like ALL. And you can see here in the graph, the black is the responders, the red non-responders. With blinatumomab, the response rate in the PH-like, both CLF2 and non-CLF2 were high, actually, 75% and 57%. So it doesn't seem that PH-like confer resistance to blinatumomab. This is a retrospective analysis looking at T-cell in children and adults with relapsed refractory ALL, and they analyze outcomes based on the genetic subtypes. And they have 19 patients with PH-like ALL, where the response rate was actually high, 84%, and appeared comparable to other subtypes. Looking at PH-like ALL survival and relapse-free survival, it didn't seem to be different based on the PH-like ALL, but again, the number of the patients was small. Here, this is our own CD19 CAR T cells. It's a recently published paper experience where we look at memory-rich CD19 CAR T cells in adults with relapsed refractory ALL. And because where our center located, we have a lot of Hispanics, so we had 40% of the actually patients who enrolled were PH-like. And although the response rate was high for these patients, 16 out of 17 achieved CR/CRi of the evaluable patient, it looks like these patients, they have lower overall survival and event relapse-free survival. But again, we have to look closer at this data. Possibly these patients more heavily pretreated, more frequently relapsed after transplant compared to a non-PH-like ALL. Now, we put together a larger experience of PH-like ALL, adults with relapsed refractory ALL with PH-like fusions. We have 96 patients. And these patients treated with one of the novel therapies, either Plena, Intuzumab, CD19 CAR, or potentially combination of these drugs. And you can see here the majority of cases, they have the CRF2 IGH. Then second, they have the CRF2 P2RY8 fusion, but also you have some cases of ABL fusion, JAK2 fusions, EPOR fusions, and the NTRK3. And again, I mean, these patients sometimes treated sequentially with these drugs. So you see patient at the time they're treated with the median lines of prior therapies were higher for patients treated with CAR T cells compared to Intuzumab, compared to blinatumab. We tend to give blinatumab early in our center because we tend to do transplant for these patients and to avoid the VOD risk. But you see that the bone marrow blast at the time of the treatment with Intuzumab was higher actually than blinatumab and CAR T cells. At the time of the CAR T cells treatment, more patients had extramedullary disease. The majority of patients who had CAR, they had transplant before compared to less patients with blinatumab and Intuzumab. And this is the sequence of the different drugs. So the majority of blinatumab patients were naive for the Intuzumab CD19 CAR, while the Intuzumab, the majority had in blinatumab. And for CAR, many of them, they have in Intuzumab and blinatumab. And from our data, you can see that the response rate, the CR/CRi, was high with all these agents, was 63% with blinatumab, 72% with Intuzumab, and even CAR T cells frequently they fail. Blina and Intuzumab, it was 90%. And among responders, the majority achieved MRD negative, and we were able to take these patients to transplant, including second transplant, in around half of the responders. This is a multivariate analysis for response and leukemia-free survival. Even blinatumab was used earlier. I mean, the response rate appeared to be lower compared to Intuzumab and CAR T cells in patients with PH-like ALL. Now, looking at the leukemia-free survival, the actual drug was given did not impact leukemia-free survival, but what impacted is actually the PH-like fusion subtype. Let me go to the next slide. So here, the relapse-free survival based on the novel therapy that was given, and at least 12 months was not different, but possibly with longer follow-up, maybe Intuzumab has lower relapse-free survival. Now, looking at the fusion itself, it seems patients with CRF2 IGH, they did have lower relapse-free survival compared to others and those with CRF2 P2RYA. And here, clearly, you can see patients who respond. If they don't go to transplant, their outcomes is poor, but if you go to transplant, that was associated with better leukemia-free survival. So salvage targeted and cellular therapy are highly active in relapsed refractory PH-like ALL. High CR rate in PH-like ALL were observed even after failing other prior novel therapies, and rates of MRD negativity and transplant consolidation afterward were high among responders to novel therapies with PH-like ALL. Just this is last thing is the experience of MD Anderson, where they're trying to actually incorporate these novel therapies early in the treatment. And after their initial experience, initially it was hyper-CVAD followed by blinatumomab consolidation. Then they added intuzumab to the hyper-CVAD. But what they saw early on, patients with high-risk genetic, including PH-like, they may relapse before they finish the first 4 cycles of hyper-CVAD. So in these cases, they moved blinatumomab early after the second cycle. But even with this approach, you can see that the overall MRD response was 95%. And interestingly, that 2 out of 3 patients who didn't achieve MRD negative, it appears that they have actually PH-like with NAP214 ABL fusion. So the question, I mean, even with this approach, will this overcome the poor prognosis of PH-like ALL to the point where maybe we don't need to transplant this patient? I think we still don't know. So how do we treat adults with PH-like ALL? I think we still have more questions than answers at this time regarding which frontline chemo backbone regimen we should use to combine or not with TKI and novel therapies, which early responder adults with PH-like benefit from allo transplant and CR1, and how to sequence novel target cellular therapies in relapsed PH-like ALL. And I think what will help actually answering these questions is having more clinical studies unique for PH-like ALL and enrolling patients on these clinical studies. I think this is my last slide. I'm happy to take any questions.
Thank you very much, Dr. Aldoss, for really an amazing and comprehensive talk. This is the best talk I've ever followed on Philadelphia-like ALL. So thank you very much for sharing with us your experience. And actually, you are very popular because you attracted an amazing number of questions. I think we can spend the whole day, if you wish, to answer and discuss some questions. So I'll try to summarize them, and I do apologize in advance if we're not able to take all of them. So let's start first by a few questions about the diagnosis. And one question from Dr. Gomez de Leon is about what would be the basic minimum diagnostic tool that would be needed outside an academic center. So like, you can drive a small, mini car, and then you can drive a Rolls Royce, but what is the minimum requirement to make the right diagnosis?
I think at least at minimum, because the CLF2 cases are the most common and the one usually drive the poor prognosis, I think like just FISH for CLF2 and IGH sometimes is enough actually to diagnose maybe close to half of those cases. But again, that's not enough because, I mean, sometimes you have to include the PCR, you need to cover the APL class, which also can be covered by FISH. But I mean, unfortunately, there is no simple way to do it, Mohammed. I mean, at our center, because we're academic, we have our own NGS and we also supplemented with FISH. I may not actually diagnose everything, unfortunately, but I think there are different, at least in the US, we have different companies where they can run actually basic testing that can give you the majority of these cases diagnosed.
Excellent, thank you very much. We have another question about the clinical features. So you mentioned nicely the biological tools, I would say, but are there any clinical features or symptoms that would direct you in front of an ALL and while waiting for your lab workup to orient or direct you into a Philadelphia-like ALL?
I mean, at least what we see, the WBC count tend to be high in these cases. And in our center, it depends what's the ethnicity of the patient. If they're Hispanic, I would suspect if they're PH negative, they're more likely to PH-like or not. I mean, beside that, I mean, I'm not aware of any other clinical finding. I see more frequently at the time of the relapse, they tend to relapse extramedullary, but the question is it because the disease biology, or it is because we're utilizing more blinatumomab in these cases early on, and this is maybe the effect of prior exposure to blinatumomab.
Okay, wonderful. So since you're mentioning the ethnicity issue, and I think you alluded to the incidence and epidemiology, which can be increased, for instance, in some subgroups, is this correlated also with an adverse outcomes in these populations?
Yeah, so actually, if you look in data preceded us knowing about the PH-like, there are a lot of publication was initially showing that Hispanic patients, they tend to have inferior outcomes of ALL. And initially, we thought this is more problem with the socioeconomic status. Maybe they're not getting treated in best places. Maybe they get diagnosed late. But I think this is more related to the biology of the disease they have. It is the PH-like that make them more chemo-resistant before the introduction of the novel therapies for relapse refractory disease.
Okay. So since we're talking about the clinic, so we have a question from Dr. Dragani, Matteo Dragani, and whether there is an association between Philadelphia-like ALL and extramedullary presentation or CNS localization.
Yeah, so I mean, as I say, I mean, I don't think we know for sure. I see it more frequently when I look at cases with PH-like ALL. More frequently, I think I see extramedullary disease, including the CNS. But it could be because we've been using more frequently blinatumomab for persistent MRD after induction, or maybe they're chemorefractory and they end up receiving blinatumomab before transplant or during the course of the treatment. So I don't think we know at this time, but it could be either the biology or the treatment they received before.
Excellent. So let's move now to the treatment, because otherwise I still have a lot of questions about the diagnosis, but apologies, guys. You can reach out to Dr. Aldoss if you wish, but we need to handle a maximum of issues. So we have, I think, two questions which are linked. And the first question from Dr. Latha, which is whether you can elaborate on maintenance treatment in this disease. And this is, I think, also in line with the question from Dr. Michael Barn from Nashville, I think. How do you handle MRD in this disease, whether before or after transplant? And of course, that brings into the podium the issue of maintenance and how you would do it.
So for cases with APL fusion, I think it makes sense to give maintenance therapy, either if you decide not to go to transplant or after transplant, more as a way to reduce the risk of relapse. But I won't use like ruxolitinib as a maintenance therapy because I think data is still early and potential toxicity with ruxolitinib in JAK and CLF2 cases. Now, for how to handle MRD, I mean, as you notice, I mean, frequently they are MRD persistent after initial chemotherapy. And in these cases, the goal to go to transplant. So I tend frequently to give blinatumomab, which seems to work really well in these cases. Before transplant, take them to transplant as a curative approach. And after that, depends what fusions, what alteration they have. I mean, if non-APL, I tend not to give actually any maintenance therapy. And I have seen actually good outcomes in these patients. You clear the MRD and go to transplant in CR1. Now, if they have MRD positive after transplant, I mean, you can use blinatumomab, but the question is blinatumomab a curative therapy by itself? And will it need a second transplant in these cases? And I tend to kind of like more CD19 CAR T cells in this setting, more as a curative approach, and potentially can avoid follow-up transplant as a curative approach after the CAR T cells. So it depends before or after.
Okay, thank you very much. So we have a question actually from Dr. Jose Luis Lopez, And actually, I'll take only one part of it for the sake of time. Whether in the context of transplant, would you use TBI for conditioning? Like, we always say in ALL, TBI is an ideal conditioning regimen, although recent trials didn't confirm this. But
yeah, I mean, to be honest, our center more biased toward FTBI. I mean, for any younger patient, we always actually do FTBI-based regimen. So at least from what we do, we give TBI. Is it better than chemo alone? This is what we believe, but may not be the case, to be honest. I mean, the chemo regimens approaches seems reasonable. Maybe relapse is more, but non-relapse mortality is less. And because high-risk disease, I still recommend to do FTBI for these cases.
Okay, good. Another question about combining TK inhibitors. Are there any data about this? And is there whatever favorite agent you would recommend?
So, I mean, there is some preclinical data. If you look here, in at least EPOR, I mean, it seems combining ponatinib and ruxolitinib has more synergy than either one alone in case with the EPOR. But again, I mean, all the data remain investigational. I mean, for TKI, it's investigational. If you talk about novel therapies, intuzumab, blinatumab, maybe this is the way to go since these cases chemorefractory. Chemotherapy doesn't work alone, and maybe this is the best approach to take these patients. But again, I mean, still investigation. Unfortunately, there is no data supporting this approach yet.
Okay. We have a question from Dr. Sergey Gritsov. Hopefully I'm pronouncing correctly. And this is about the use of anti-CD38 monoclonal antibodies. And I guess, for instance, in the relapse refractory setting, any experience with this? And actually, do the cells express CD38?
B-cell ALL in general, they do. The more clinical experience is in actually T-cell rather than B-cell, especially in low disease burden, MRD setting, and post-transplant. At least my understanding, the COG, the pediatric study, the COG study, they closed the B-cell arm because I think the data wasn't as encouraging, if not mistaken, but the T-cell arm is open. So I'm not aware of any actually CD38, target CD38 in PH-like ALL. But again, it seems there is more encouraging data in T-cell rather than B-cell ALL.
Okay. One last question, Ibrahim. And assuming today you have access to all kinds of drugs, TK inhibitors, JAK inhibitors, you have the BiTEs, you have antibody drug conjugates like inotuzumab, you have the CAR T cells, you have the JAK inhibitors, you have the right donor for transplant, and you have a patient who is 35-year-old, fit, and willing to listen to whatever you want. What would be the ideal sequence of treatment from induction until cure, hopefully?
Yeah, so Mohammed, I mean, the issue is usually, at least in my center, we get the pH-like analysis a couple of weeks later. So frequently, we start the patient on chemotherapy. And we have a study here where we combine venetoclax with a standard pediatric inspired regimen for this patient. And if they have persistent MRD only, I tend to give them blinatumomab. It's very efficient in clearing the MRD. And if they have a donor, the answer is to take them to transplant after that. Now, if I knew about the pH-like status before, again, I mean, we have clinical studies, so usually we put the patient on it. But if not, I mean, he's 35. I mean, you cannot give blinatumomab and intuzumab unless the patient on clinical study as frontline therapy. So if there's no clinical study, I would still using AYA regimen. But once I find out about the pH-like ALL and they're MRD positive after induction, I don't keep going with chemotherapy. I usually go quickly to immune therapy. I mean, blina, the nice thing, because it's safe before transplant, I may choose blina. It's off the shelf if the disease burden is low, MRD setting, so I can take them to curative transplant.
Well, thank you very much, Ibrahim. That was really a fascinating webinar and discussion. I learned a lot from you, and this topic will continue, I think, to generate a lot of interest, because it is definitely, it remains an unmet medical need. I'm sure you can reach out to Dr. Aldoss if you would like to discuss further a specific question. But for the meantime, I'd like to thank you all for being loyal to the ICH Journal Club. I hope you have enjoyed this double-header webinar this month about TALL and Philadelphia-like ALL. And as always, my conclusion, wherever you are, please stay safe and keep well, and hope to see you soon in another ICH activity. Thank you.